Next speaker is Dr. Anup Toshniwal from Aurangabad, and he'll be talking to us on circulating tumor DNA-guided de-escalation targeted therapy for advanced NSCLC. Over to you, Anup.
Thank you. At the onset, I thank organizers for inviting me to give this talk. My talk is the topic is circulating tumor DNA-guided de-escalation of targeted therapy for advanced NSCLC. It is a non-randomized control trial. This is based upon a JAMA oncology paper published in June 13, 2024 by this Chinese group. What is the importance of this study is that until now what we do is we give uninterrupted targeted therapy until disease progression or intolerable toxic effects are there for NSCLC which patients having driver gene variations. However, this is costly. Patient has to continue treatment till progression or toxicity. Drug resistance becomes inevitable in these cases. The objective of the studies was to assess the clinical feasibility of adaptive de-escalation of TKI treatment guided by circulating tumor DNA for achieving complete remission after local conservative therapy in patients with advanced NSCLC. Design, setting and participants of this study. So this was a prospective non-randomized control trial which was conducted at a single center from June 3, 2020 to July 19, 2022, included 60 patients with advanced NSCLC with driver variations without radiologically detectable disease after TKI and LCT. The median range of follow-up time was 19.2 months. Data analysis was conducted after the closure in over a period of 1 year. The intervention was cessation of TKI treatment after initially patient was treated with TKI and had underwent an LCT, and after which there was no radiologically detectable disease and follow-up every 3 months. What also was required was that the CEA and the ctDNA has to be negative. Then treatment was restarted in patients who had either RECIST-defined radiological progression or had detectable ctDNA or had elevated CEA. Whichever manifested first, treatment was restarted and patient was put on surveillance in patients who were continued on observation. So main outcome and measure was PFS. Secondary endpoints included objective response rate, time to next treatment, and overall survival. Now this is the chart which shows what actually happened. So what they did is they screened 13 patients, 73 patients, 13 were excluded, 60 were enrolled. Here they were actually initially treated followed by LCT. Year after treating, there was no radiologically detectable disease. ctDNA was negative, CE was negative. So out of this, 14 patients were just kept on observation. Out of 60, 46 were retreated because either they had a positive ctDNA or elevated CEA. This was the group B, and group C was where there was radiologically confirmed progression of disease. Now baseline demographic and clinical characteristics of these study patients were like stage 3 and stage 4 were included, smokers were included, all patients for adenocarcinoma, it was not squamous were not included in this study. Majority of these patients had EGFR mutation. ALK-ROS contributed very less, other mutations were not included. The target drug pair initially treated and on progression which was treated was this, and the patient which had organ with metastasis as baseline was 1, 2, majority were 1, and even brain met patients were included, and the surgery was the main intervention in LCT. Here that made the factor in when we analyzed this study. So what happened is here initially these patients were treated. Here since there was no radiological evidence of disease and there was no serological evidence or the molecular evidence of the DNA evidence of active disease, patients were discontinued treatment. These patients with beige color, they had treatment breaks. This is the prior TKI treatment, and these patients were retreated, and arrow shows that patient treatment is ongoing, and patient without arrow, the bars which are without arrow, they are kept again on observation, and here multiple times they were taken off on the TKI. So coming to the results of the total study sample of 60 participants, median PFS was 18.4 months, and total treatment break duration was 9.1 months, which was median. What is interesting is 14 patients who were kept on observation, they had treatment break duration of 20.3 months. So median, they were not treated for 20.3 months, who did not have any radiological, serological or circulating DNA positivity after initial treatment. 13 patients who had either serological relapse in detectable ctDNA or CA. Here after starting treatment, they had a median PFS of 20.2 months and they enjoyed a treatment break-free duration of 8.8 months. The group C, which had 15 patients who underwent treatment with TKI, had a PFS of only 5.5 months after radiological progression of disease. For 27 patients, those included 12 in group B and 25 in group C, who had experienced progressive disease, TKI retreatment response rate was 96% and the median time to next treatment was 29.3 months. The data for overall survival is immature. 12 out of 24 patients who achieved sufficient tumor regression opted to discontinue treatment in this group of patients. In group B, ctDNA was undetectable in 96% of patients, that is 25-26 after 3 months of retreatment with prior TKI, and CA reached a normal level of 3 out of 5 patients. 2 other patients exhibited degree CA levels that persisted after a normal range. For patients who received TKI retreatment, the toxicities were grade 1 and grade 2. No major concerns were there after retreating. So this is the diagram which shows group B enjoyed almost, they are enjoying a PFS treatment free interval of 20.3 months. Group B somewhere here PFS of 20.2 months, and who had radiological progression had only PFS of 5.5 months. And the metastatic pattern after relapse was that 9 had developed intrathoracic mets, 41% had developed extrathoracic metastasis, and 7 developed both. Additionally, 3 patients had growing oligometastatic nodules in lung, underwent a second wedge resection per the decision of multidisciplinary team, and 1 other patient received drip radiotherapy locally. Of the 27 patients who had progressed, 12 eventually experienced progression while receiving retreatment with prior TKI and were instructed by the physician to take treatment in the form of chemotherapy. 7 received third generation, 4 received chemotherapy, 1 received Airlo plus BAVE. To conclude, the findings of this non-randomized controlled trial suggest that this is adaptive de-escalation TKI strategy for patients when NSCLC is feasible in those with no lesions after LCT and a negative ctDNA and CED test. This might provide a de-escalation treatment strategy guided by ctDNA for the subset of patients with advanced NSCLC. Thank you.
So thank you very much, Dr. Anup.